nakutin. Oke. Tes. Tes. Good morning, ladies and gentlemen. Welcome to Rudy Soetikno. Oke. Cukup kencang ya? Good morning, ladies and gentlemen. Ya segitu suaraku. Halo.
sini.
Oh, oke. Oh, atau Anda mau ngambil aja, biar malu deh kayaknya.
Kami sih ada sih, kalau mau itu kita sediain laptop, kalau Bapak mau hanya
Pindahin aja ya?
Iya.
Ya udahlah, pindahin aja Mas, Anda ambil, terus biar nggak repot kan?
ya,
Flash disk aja deh ya. Ini.
Ini Pak, sudah kami sediakan.
Oh
Kalau
iya.
mau atau mau pakai punya Bapak juga nggak apa-apa.
Boleh, Anda ambil aja Mas. Ini mau yakin aja semuanya tuh ada gitu loh Pak. Khawatirnya ada yang ketinggalan.
Bapak mau pakai audio? Perlu ada slide video gitu? Nggak ada.
Oh iya, Pak. Oke, Mas. Silakan.
Juga sudah bisa sih kalau pakai Mac.
Oh gitu, udah bisa, udah nyambung.
Gimana?
Ini juga nggak apa-apa sih.
Iya.
Gitu aja ya Pak ya.
Supaya nggak bingung takutnya.
Iya ya.
Pakai ini.
Biar nggak repot ya. Oke, sip. Iya dah. Oke, makasih.
Siap, Pak.
You remember me when the west wind moves upon the fields of barley. You forget the sun in his jealous sky as we walk in fields of gold. So she took our love for to gaze a while upon the fields of barley. In his arms she fell as her hair came down among the fields of gold. Will you stay with me? Will you be my love?
Good morning, ladies and gentlemen. Welcome to Titan Theater and welcome to Rudy Soetikno Memorial Lecture. Thank you for your attendance on this historical event. We would especially like to welcome Professor Matthias Runkel from Germany, Professor Ari Haryanto, Chairman of Perhombetin Indonesia, Dr. Lothar Benning from Germany also, Dr. Hilman Tajuddin, also from Perhombetin Indonesia, Ibu Heti Soetikno, as the co-founder of DEXA Group, Bapak Ferry Soetikno, as the CEO of DEXA Group, all distinguished audience from Kementerian Kesehatan, Badan POM, BPJS and staff, and other regulatory bodies, also to our friends, hematologists, medical oncologists, internists, other medical specialties from all over Indonesia, also to academics, hospital leaders, hospital pharmacists, other medical professionals, as well as the media and other distinguished audience not previously mentioned. Today we will have Rudy Soetikno Memorial Lecture, which is a scientific lecture and discussion on healthcare and pharmaceutical topics. And as a tribute to DEXA Medica founder, which is the Honorable Lieutenant Colonel Dr. Rudy Soetikno Apotheker, who dedicated his life for the advancements of Indonesian pharmaceutical field. Now, we would like to invite Mr. Ferry Soetikno, as the CEO of DEXA Group, to deliver his opening remarks. Please, Pa Ferry, have the stage for your opening remarks.
Thank you very much, Pa Raymond. Good morning, distinguished participants and experts to the first Rudy Soetikno Memorial Lecture this morning. First and foremost, let us bring our praise and thanksgiving to God Almighty for His blessing that we can come together to this international scientific event. Second, I would like to thank each of you for taking your valuable time to be active participants, especially the expert panels, Professor Matthias Rummel, Dr. Lothar Benning, both from Germany, and Professor Ari Haryanto and Dr. Hilman Tajuddin from Jakarta. Now, let me share with you the three main intentions for conducting this event. First, we would like to commemorate, remember our beloved father, leader, and guru, Pak Rudy Soetikno, as someone who puts his value on the advancement of Indonesian pharmaceutical industry. His dedication and efforts are none other than that Indonesia is in the forefront and never left behind. Second, we would like to share in his memory the times when he endured his sickness of lymphoma starting in May 2010. Professor Aru Sudoyo was the first medical oncologist to diagnose his lymphoma in Jakarta. Then later on, another doctor in Singapore General Hospital also came up with the same diagnosis. A regimen of R and CHOP was considered as the chemotherapy option at that time. Pak Rudy, being a pharmacist, critical, systematic, considered and put more thoughts to take CHOP for his treatment. Many side effects and adverse reactions for a heart patient, as he was, were put within his main consideration. I remember, still in the SGH compound, I suggested that we contact our good friend, a medical oncologist in München, named Dr. Lothar Benning. On the phone, spontaneously, Dr. Benning suggested that he got a combination of R and B, which were rituximab and bendamustine. This option delighted Pak Rudy very much. In short, he went to München in September 2010 to undertake his first chemo cycle. He tolerated it well, and to cut the story shorter, he subsequently received several R and B cycles until his lymphoma receded significantly, as evidenced in his clinical conditions at the time. Third, we would like to share his commitment on DEXA Group core purpose, expertise for the promotion of health. Within his R&B treatment, he mentioned to us several times that it is a pity, it's a shame that access to bendamustine is very minimum because this product was not known in Indonesia nor in Singapore. And it was expensive and difficult to import such a product to this country. One bright afternoon in 2011, he summoned me and several other directors in his desk, and he gave a very clear instruction. We have to build an injectable oncology plan in Indonesia so that many Indonesian people, patients, will have access to quality oncology products. And we will have to build our own self-reliance and reduce our dependency on importing finished product, especially oncology, from outside. On Tuesday, 19th of August 2014, Pak Rudy was received by Her Excellency Ibu Dr. Nafsia Mboy, MPH, our Minister of Health at the time, at her office. It was very interesting for me to witness how both of them were enjoying a very open conversation until finally, Minister Nafsia Mboy stared at him and put a blunt question. I know you want me to inaugurate FONCO, right? Pak Rudy was a little bit surprised, but he nodded with a very happy face. At the end of that conversation, Ibu Naf concluded, yes, I will do it gladly. The inauguration ceremony took place on Tuesday, the 23rd September 2014 in FONCO plant in Cikarang. Now, let us see Pak Rudy in his welcome speech on that occasion.
Saya sendiri ialah mengalami 4 tahun yang lampau, di mana ialah saya menderita penyakit kanker limfoma, dan sebagai seorang pasien penderita jantung, saya ialah tidak bisa menerima resimen yang biasanya ialah diberikan kepada para penderita kanker. Saya beruntung, seorang kawan di Jerman, seorang onkolog ialah menelpon Pak Ferry dan mengatakan, berikanlah pada ayahmu suatu kombinasi obat terdiri dari bendamustine dan rituximab. Tapi sayangnya bahan zat bendamustine tidak terdapat di Singapura, tidak terdapat di Indonesia, malahan ialah tidak dikenal di tempat-tempat ini. Maka terpaksa ialah saya dan keluarga berulang kali ialah harus pergi ke München untuk mendapatkan pengobatan kemo daripada resimen ini. Dari tahapan awal telah dipikirkan bagaimana ialah membuat fasilitas ini sedemikian rupa sehingga kapasitasnya ialah cukup melayani ialah masyarakat Indonesia, dan produk yang dihasilkan akan merupakan produk yang canggih. Fasilitas tidak hanya memenuhi CPOB GMP daripada Indonesia, tapi fasilitas ini ialah juga memenuhi GMP dari Eropa dan even dari Amerika. Obat-obat buatan Indonesia ialah akan mendapatkan priority daripada pemakaian baik di CKN maupun BPJS.
Let me continue. Then the first product of FONCOPAC consisting or containing paclitaxel was launched 1 year later on the 23rd September 2015. Subsequently, Indonesian National Agency of Drug and Food Control, Badan POM, issued a marketing authorization of FONCOMustine containing bendamustine in November 2016, and FONCOMustine was eventually launched in Indonesia in January 2017. Ladies and gentlemen, distinctive audience, Pak Rudy was always committed to build the Indonesian pharmaceutical industry. His core purpose, expertise for the promotion of health, always reverberates in our heart. His commitment to build an oncology plan has been fruitful in delivering many cancer drugs into Indonesia at this moment, and also to be exported to several other countries, as he mentioned. Now, bendamustine, manufactured by Fonco and marketed by Feron, is available in Indonesia for many patients who are in need of it. And today, the distinguished panelists will present their views on bendamustine for the benefit of so many doctors in Indonesia. I wish that this event will be beneficial for each of us in Titan Theater today, and finally, for so many patients in need. As the legacy of Pak Rudy Soetikno continues, we at DEXA Group will carry his message and strive to make Indonesia always at the forefront of pharmaceutical sector for many years to come. Thank you very much.
Thank you very much, Pak Rudy Soetikno, for your warm welcome. Let's have another applause for Mr. Rudy Soetikno. Ladies and gentlemen, as you may not be aware that we are actually having live streaming on YouTube, this particular event. It's being broadcasted on YouTube, so you do not have to take any picture or nor video because it's there in the file on the YouTube. Yeah. This Rudy Soetikno Memorial Lecture is intended to commemorate Mr. Rudy Soetikno's contribution to the Indonesian healthcare and pharmaceutical industry. In order to understand his contribution, let us take a look at the following video profile, which has been previously prepared to honor his legacy.
Dedicating his life for the country. Lieutenant Colonel retired CKM DRS Rudy Soetikno APT is reminisced as a true pharmacist. He devoted his life to develop the national pharmacy. Bapak Rudy Soetikno studied pharmacy and graduated as a pharmacist in 1959 from the Faculty of Pharmacy, Bandung Institute of Technology, ITB. He started his career as a pharmacist in Abadi Pharmacy, Jakarta. In the middle of his career, Bapak Rudy Soetikno answered the mandatory call from his country in 1960. He joined the draft and was assigned in AK Gaini Military Hospital, Health Unit of Regional Military Command, Kesdem 4, Sriwijaya Palembang. He transformed the Dobek Kesdem 4 room into a simple facility of injecting drugs production. Due to his persistence and achievement, Commander-in-Chief of Armed Forces General M. Pangabean awarded him an appreciation. To dedicate his knowledge, Bapak Rudy Soetikno channeled out his passion in teaching by becoming the Director of Pharmacy Assistant Vocational School in Palembang and the lecturer in the Medical Faculty of Sriwijaya University from 1962 to 1972. His sincerity in dedicating his life as a pharmacist motivated Bapak Rudy Soetikno to solve the scarcity of drugs in South Sumatra. He then established PT DEXA Medica in 1969. DEXA is derived from the word deca, that signifies 10. The word reflects perfection that is proven by the best quality of drugs being produced. In order to voluntarily contribute towards the society by providing quality affordable drugs, Bapak Rudy Soetikno initiated the production of OGB DEXA by DEXA Medica in 1991. DEXA Medica is the first private company that produces OGB in Indonesia. Bapak Rudy Soetikno's persistence, rigor, and visionary attitude have been guiding DEXA Medica into a reputable national pharmaceutical company, well known both in the country and the region. DEXA Medica has been exporting its products to more than 10 countries. Building an end-to-end competency as an embodiment of the principle expertise for the promotion of health is reflected throughout all company's activities, including PT Ferron Par Pharmaceuticals, that has been operating since 2001, has a certified quality system issued by both GMP and BPOM, the Republic of Indonesia, the Indonesian National Agency of Drug and Food Control. It is also GMP UK MHRA certified for the facility's solid dosage line. PT Anugrah Argon Medica, DEXA Development Center, and PT Beta Pharmacon. Similarly, DLBS was established under the mission to search for and develop pharmaceutical and biopharmaceutical products by benefiting from the Indonesian natural resources. DLBS is the living proof of Bapak Rudy Soetikno's vision to support the national independence of drugs raw material. Importing dependency of cancer drugs, as well as its high price, cause difficulty for people in need to access the drugs. It is the reason behind Bapak Rudy Soetikno's noble intention to establish an oncology drug factory, PT Fonco International Pharmaceuticals. Fonco was officially inaugurated in 2014 and has been being marketed since 2015, both in the country and globally. The factory is an oncology drug factory designed under the standards of EU, TGA Australia, and PIC-S GMP, complemented with a conceptual design of international GMP consultant and with an up-to-date quality system. Bapak Rudy Soetikno's devotion towards the education of pharmacy is proven by donating a set of laboratory equipment for the Faculty of Pharmacy ITB. The equipment handover was conducted on August 18, 2015.
Sewaktu perusahaan ini ialah didirikan, apa yang ingin dicapai oleh perusahaan ini? Apa yang mau diabdikan oleh perusahaan ini kepada masyarakat Indonesia dan manusia pada umumnya? Saudara-saudara sekalian, jawabannya semuanya ialah telah mengetahui, telah berulang kali dikatakan apa yang merupakan core purpose daripada perusahaan ini, yaitu expertise for the promotion of health.
Bapak Rudy Soetikno, we will continue your dedication. We will continue your dreams and fights to improve the health in Indonesia.
Thank you, ladies and gentlemen. Let's give our love once more to Mr. Rudy Soetikno. As has been mentioned previously, Mr. Rudy Soetikno endured non-Hodgkin lymphoma. We are very privileged to have Dr. Luther Benning, who actually amongst us and became his oncologist and treated personally Pak Rudy Soetikno. And we would like for him to share his experience in treating Pak Rudy. Dr. Benning received his board certification in internal oncology from the University of Munich. He subsequently established a comprehensive oncology practice with the Department of Radiology and Internal Oncology in Munich. He was also the head of the Association of Oncologists in Practice in Bavaria, as well as member of the board of the Association of German Oncologists in Practice. So let's have Dr. Luther Benning please come on stage and share your experience in personally treating Mr. Rudy Soetikno.
Dear family Soetikno, dear colleagues, I would like to say thank you for this invitation. I'm glad and proud to be here to present the medical history of a patient who was suffered from follicular lymphoma. This patient was Mr. Rudy Soetikno, to whom this lecture is dedicated. I was the responsible person for the lymphoma treatment. Here are the data of the patient. In May 2010, the diagnosis of a malignant lymphoma was made. Histopathology, follicular lymphoma, centrocytic, centroplastic, WHO staging grade 3 with a thoracic and abdominal manifestation. His comorbidities were in 1989 coronary bypass, in 1994 abdominal aortoplastic due to a dissection of the aorta, in 1998 a heart attack with implantation of 2 stents. The lymphoma manifestation at time of diagnosis were right supraclavicular, right infraclavicular, right axillary, abdominal left para-aortal. The clinical findings: palpable lymph node, right axillary, size 5 centimeter, no other pathologic findings, no B-symptomatic, no other complaints. Based on this data, we make the following decisions. Not to start with chemotherapy. The strategy was watch and wait, because the patient is without any complaints. The aim of the treatment in this case is to control the disease, not to cure the patient. 3 months later, we saw a significant increase in all lymph node manifestations. In addition, a lymphedema of the right arm developed, as you can see in the increase of the lymph node size. Now we saw indications starting with chemotherapy. 2 favorite regimens for the first line are BR and R-CHOP. Matthias Rummel did the main work on this field, and he will tell you in the next lecture more of this field. BR is bendamustine and rituximab. Bendamustine EV 90 milligram per square meter, rituximab 375 milligram per square meter, repeated every 4 weeks, and R-CHOP, as you know, cyclophosphamide, vincristine, prednisone, and also repeated 4 weeks. Comparing BR with R-CHOP in this case, BR shows more complete remissions and a longer progression-free survival in several tries. It has a better side effect profile, and R-CHOP is an absolute contraindication in patients with heart disease. Therefore, the decision was clearly bendamustine rituximab. After administration of 4 cycles of BR, we saw a significant reduction of lymph node enlargement in all manifestations, no detectable lymph nodes, abdominal, and no relevant side effects. Result, a partial remission. You see the decrease of the lymph node side on the right. The maintenance treatment after finishing the 4 cycles were rituximab 375 milligram every 3 months. These were done from January 2011 to July 2012. In 2012, we saw a progressive disease with significant enlargement in all lymph node manifestations. In this situation, we have done 2 further cycles of BR with the result of a partial remission. You see the reduction of the lymph node size on the right. In January 2015, we saw a significant progression with increase of all lymph node manifestations, recurrence of the abdominal lymph node enlargement with obstruction of the left kidney, and skin infiltration of the right thoracic wall. The next chemotherapy regime, the new one, was BO with bendamustine 90 milligram per square meter day 1 and 3, obinutuzumab 100 milligram day 2, and 900 milligram day 3. Obinutuzumab is a monoclonal CD20 antibody, and it shows effectiveness after rituximab resistance in follicular lymphoma in several trials. The pre-medication for this BO regimen are glucocorticoids, antihistamine, allopurinol, and adequate hydration. The possible adverse reaction with this regimen are breathing problems, heart palpitation, cough, nausea, vomiting, fever, chills, diarrhea, anaphylaxis, and acute thrombocytopenia. And tumor lysis syndrome. The drug effect of obinutuzumab is based on a fast cell death with possible extreme elevated blood uric acid values in patients with high tumor burden, with a risk of renal failure. The treatment is respiricase. Respiricase is a drug which converts uric acid to allantoin. After first application of obinutuzumab, we saw an impressive phenomenon with decrease in tumor burden within 2 days, nearly at half of size. Kidney obstruction disappeared, visible reduction of the skin infiltration, and no relevant side effects. The patient was able to do his daily work 1 day after finishing the infusions. Here you see the skin infiltration of the chest before treatment, 2 days after treatment, and after 5 cycles of treatment. In the last picture, we have no sign of skin infiltration anymore. Before we could continue with the last scheduled cycle of this treatment, the patient died on July 13th, 2015 due to a heart attack. The lymphoma at this time was under control. Looking back, 2 questions could come up. Was it the right decision to stop the first treatment schedule after 4 cycles? Normal is 6 cycles of BR. Our reason to do that was due to the age and the comorbidities of the patient. The second question, was it the right decision to perform no maintenance therapy after 6 cycles of BR? Our reason was it seems that the maintenance therapy after 4 cycles of BR was not effective. Conclusions. Bendamustine in combination with CD20 antibody is a very effective therapy in follicular lymphoma. Bendamustine is now available in Indonesia, and it provides you with an effective drug for lymphoma patients. After the medical history, I would like to say some personal words regarding the character of Papa Mr. Soetikno. During the 5 years of treatment, I saw always a friendly, humble, restrained patient, never in bad mood, always hopeful. He was my last patient after about 40 years of activity in the oncologic field. I'll never forget him. Thank you for your attention.
Thank you very much, Dr. Luther Benning. Please, audience, let's have another applause for Dr. Luther Benning. Now that you have learned from Dr. Benning in treating Mr. Soetikno himself, in order to complete the whole story, we are inviting Professor Matthias Ramon to present on the role of bendamustine in the treatment of follicular lymphoma, especially when it connects to the story which was told by Dr. Benning just now with regards to Mr. Rudy Soetikno. Please, Professor Ramon.
So, good morning to everybody. I feel honored and I want to thank you that I got a next invitation to this country. I was here in July 2017, the first time in Indonesia, to talk and to discuss about the best treatment approach in patients with lymphoma. So I'm very thankful that I was invited again by the family Soetikno on this very special event, and I would like to show you all the results we have obtained with bendamustine. So I will give 3 talks today. The first is the role of bendamustine in follicular lymphoma, and afterwards I will also show which kind of improvement was achieved in the last decades in treating patients with other kinds of lymphoma, such as aggressive lymphomas. First, I would like to show you the role of bendamustine in follicular lymphoma. So this is my name, and I'm the director of the Department for Hematology and Oncology in a university hospital in Germany in the city Gießen. And also I'm the chair of a large German cooperative study group which comprises more than 150 study sites in Germany to conduct large clinical trials, as you will see. First, I would like to show you a bit the history of bendamustine, because it is a unique story. Bendamustine is not new to the field. Bendamustine is more than 50 years old. However, only a small portion of the world did know it, because it was produced in the former east part of Germany. That was in the time when there was a wall in between the 2 German countries, and bendamustine was developed on the communistic east part of Germany. They used bendamustine, they produced it, however, they never wrote a manuscript, they never went to international meetings and showed their results. That was the reason why the rest of the world never had any idea that bendamustine is available. They used it in lymphoma, chronic lymphocytic leukemia, multiple myeloma, Hodgkin's disease, breast cancer, and small cell lung cancer. This were the group in 1960. It's a very old photo, black and white. These 4 people developed bendamustine. They had a very interesting idea. They already did know that the one most important chemotherapy are alkylating agents like chlorambucil, melphalan, cyclophosphamide. And they know that there are purine analogs in the field like fludarabine and cladribine. So this is the chemical structure of bendamustine, and this explains the idea of these people. First, you see the nitrogen mustard group, and this is known, the alkylating agent cyclophosphamide, but it's also present in bendamustine. So we could say bendamustine is another alkylating agent. However, this is not so easy, because you see here the chemical structure of cladribine or fludarabine, and you see the red structure. This is a benzimidazole ring, and this is also in the bendamustine. So bendamustine is a hybrid between alkylator and purine analog, and this is very unique. There is no other comparable drug in the market like bendamustine. The mechanism of action is like in other alkylators. It is, however, there is a very important key difference between bendamustine and other alkylators, and this is, as mentioned before, the bendamidazole ring. And I think this unique structure contributes to its very unique anti-neoplastic activities. I would like to show you only one result out of all laboratory results, but I think this is the most impressive result just from the laboratory. This is the famous National Cancer Institute compare analysis for cyclophosphamide. So the question is in laboratory, how many drugs are similar to cyclophosphamide? And no surprise, when the correlation coefficient is higher than 0.8, like here, all the drugs have a similar way of action. No surprise, these are all alkylators who have the same way of action like cyclophosphamide. When you do the same test with bendamustine, you find 0 compounds who have the same way of action as bendamustine. You see it here, 0 compounds were found to have a correlation. And that, again, shows bendamustine is a class of its own. I will now discuss the standard of care for patients with low-grade lymphomas with a special focus on bendamustine. What is the international consensus for the treatment for patients with indolent low-grade lymphomas? Yes, there is still a role for watch and wait, because we know we cannot cure this disease. Therefore, if a patient has no symptoms, we make watch and wait. If we see an indication for treatment, the combination of immuno and chemotherapy is a standard, and this is most often rituximab plus chemotherapy. And I will show you in my next slide that bendamustine plus rituximab is the preferred treatment regimen. Also, I will discuss briefly if the maintenance with rituximab has any role, and also what is the consensus in the international community. Stem cell transplantation does not play a role in follicular lymphoma. We have consensus and we have open questions. What is the open question? How to improve results when patients have a relapse or are refractory? Is the maintenance really useful? And what is the role of the new antibody obinutuzumab, which already was shown to you by my previous speaker and colleague, Dr. Lothar Böning. I would like to show you now the history of the new era of bendamustine. Bendamustine, as I told you, was available in east part of Germany, 1960. When the two German countries merged together, 1989, 1990, the colleagues from East Germany spoke to us because there was no wall in between. We were one country. And then the people from East Germany told me and other colleagues, use bendamustine in lymphoma. Why you do not have bendamustine in West Germany? We were asking, what is bendamustine? I have never heard this word. Oh, this is our typical chemo. Use it. You know what we did in the old days, 1990? We kept on smiling and said, okay, we will consider. But thinking was, no way. It comes from communistic part of Germany. No way. It cannot be good. But after a while, 2, 3, 4 years, we used bendamustine in some patients who are refractory. And we were seeing so good results. And in this time, I was a young doctor, 1993, and I started my career in doing clinical studies. And I did a study, this was the very first under GCP and published in a peer-reviewed journal, a typical phase 2 study, bendamustine plus rituximab, phase 2 in relapsed, published in Journal of Clinical Oncology. These were the results. 63 patients, the overall response rate was 90%, in mantle cell lymphoma 75%, the median progression-free survival 2 years, all patients with relapsed disease. And we reported on the ASH meeting, the side effects were very low. American people didn't believe, because the first question was, what is bendamustine? Why the Americans don't have it? The answer was, do your studies, maybe you can get the license to North America, and that is what happened. Afterwards, the Americans did the same study 3 years later, and they had the same patient population, and they found the same response rate and the same progression-free survival. So internationally confirmed bendamustine in relapsed disease. So when we did our phase 2 study, you probably know the publication will end with the last sentence, further studies needs to be done. We need to have a randomized trial against the standard of care. So we felt motivated with the phase 2 study to continue the clinical development. We initiated 2 phase 3 studies, one in relapsed disease and one in first line. And this is relapsed disease. We compared bendamustine, rituximab, against fludarabine rituximab in patients with relapsed follicular, Waldenström, marginal zone, and mantle cell lymphoma. It was a German-wide study of the STEEL study group indolent lymphomas, and we had 55 centers. The study was done between 2003 and 2009, and the patient characteristics showed that the median age was 67, all patients with relapsed disease, and the response rate were already very different. 82% with bendamustine and 51% only with fludarabine, translating into a huge improvement with bendamustine rituximab in terms of progression-free survival compared to fludarabine, in terms of PFS, and also in overall survival. The p-value was 0.012. We concluded for relapsed patients, when they have not been treated with bendamustine before, the best treatment option is bendamustine, but not fludarabine. The most important question, however, is what is the best frontline treatment? Because you have a follicular lymphoma patient who is typically an older patient above 60 years old. And this is very important to consider. Can be used an aggressive treatment or should be a less aggressive treatment needed? Who knows the answer? We need to do a randomized trial. So this is an open question. What is the best frontline treatment? This is what the NCCN guidelines is telling you in 2015 and in 2016 until today. Very important to know, at this lymphoma slide, NCCN makes preference order, not alphabetical order. This does not happen so often, that the NCCN guidelines tell you what is treatment number 1. And it is bendamustine rituximab. Only second is R-CHOP and R-CVP. And why NCCN guidelines have made this decision? This was based on the German trial, the STEEL trial, comparing bendamustine rituximab against R-CHOP. I will discuss this trial, and later on I will discuss the French trial addressing the role of rituximab maintenance. This was our German trial. This was my most important step in my clinical career, that I initiated a study comparing bendamustine against CHOP plus rituximab. We were asking the question, why should we treat a patient above 60 years old with R-CHOP? Maybe some other treatment is as good as R-CHOP, but does not have so many side effects. To remember, this is 4 drugs: cyclophosphamide, anthracyclines, vincristine, prednisone. This is only 1 drug. The dose of CHOP and rituximab, everybody knows. The dose of bendamustine is 90 milligram per meter square. Why 90? When you look in the official paper, typically all over the world it is written 120 milligram per meter square. This dose is too high. It is not a good dose. But why 90? I would like to tell you the truth. And sometimes the truth, even in science, is a little bit funny. Why is 90? Because I did the study here in 2003. 2003 was 15 years ago. I was 15 years younger. And when you are younger, you have some more crazy ideas. So I was writing the protocol, and I wrote down in the dose, we do 100 milligram per meter square, comparing to CHOP. Everybody asked me, why 100? Why not 120, 130, 110? I said, nobody knows. We have never done a study. Let's do 100. However, on the day when I submitted the protocol to the authority, I woke up in the morning and I saw the mystic number 90 in my dreams. And I thought 90 looks so more intelligent than 100. And it does. It is really true. 90 sounds like you have a lot of thoughts. 100 would look very normal, but 90 looks very clever, very intelligent. Interestingly, 375 milligram per meter square rituximab. Who knows why 375? Maybe 400, maybe 380. Why 375? The same story, the company Roche, Genentech, when they had the first trial, produced only 1 limited amount of antibody divided by 60 patients by 4 cycles, and it was 375. No dose-finding study. And the world is doing 375 for 20 years, never having any evidence that this is the optimal dose. So it's interesting, 90 plus 375. Anyhow, we did a large study, and it was 81 centers. Of note, this lymphoma trial was selected for presentation in the plenary session of the ASCO in 2012. And then it was published in 2013 in The Lancet, and I have given an update in the last ASCO meeting. We had here first-line treatment. The median age was 64, and we had the typical low-grade lymphomas. patient characteristic between the two arms were the same, 64, 63 years, stage 4, 77, 77%, the international prognostic index 37, 34, all the same. Side effects were very much different. This is what we had already in our experience. Bendamustine has less hematotoxicity, 12% grade 3 and 4 compared to 38% with CHOP. Also, GCSF needed is less often than with CHOP. So bendamustine was better tolerated in terms of leukocytopenia. And non-hematological toxicity, bendamustine also was favorable. No hair loss, but hair loss with CHOP, very small incidence of peripheral neuropathy, no cardiotoxicity, stomatitis less often, infections, complications less often. The only thing what was seen more often with bendamustine was some time of skin erythema, which can happen to 10 to 15% of the patient as a skin reaction. Response rates were the same, more or less 92 against 91%, which already was a big surprise that bendamustine has the same response rate. However, the surprise was really a big one when I showed progression-free survival, because the curve, which is above the other one, is bendamustine rituximab. So it came out that bendamustine was even much better in terms of efficacy, not only less toxic, but also more efficient than the standard treatment R-CHOP. A big surprise to the international community. And of course, this did convince the NCCN guidelines to put bendamustine on the #1. We showed the results for follicular lymphoma, marginal zone, Waldenström, and mantle cell lymphoma. In all 4 diseases, the curve with bendamustine was better than with CHOP-R. This is from 2017. This is the long-term update. You see here that the curve goes 10 years, 12 years, 14 years, because the study was done in 2003 and we still do follow up the patient. Even after 14 years, the curve with bendamustine is much better in disease control than with CHOP. This is time to next treatment, and you see that even more than 50% of the patients initially treated with bendamustine did not need a second-line treatment after 10 years. This is a really good disease control, that the patients do not need a second-line treatment per average when comparing it to CHOP-R. Was there any severe side effect in terms of long-term toxicity? For example, secondary malignancy, we see no difference. Secondary malignancies over 10 years, 39 with BR compared to 47 with CHOP. No difference compared to the standard regimen. Overall survival was not improved at the moment because all patients who relapsed after R-CHOP were treated consecutively with bendamustine rituximab, and this, of course, was good for the patient with relapsed disease and did influence the overall survival. What we saw is that complete responses were better in terms of overall survival than partial responses, like we see it in diffuse large B-cell lymphoma. And also what we saw is that patients with a high LDH had a shorter overall survival than patients with a normal LDH. And the normal LDH overall survival after 10 years, the overall survival is 80%. And here in patients with a normal LDH, patients with bendamustine rituximab have a longer overall survival than patients with CHOP-R. So our conclusion was bendamustine is clearly the better treatment. It has a prolonged time to next treatment and progression-free survival. We need by far less second-line treatments, no increased rate of secondary malignancy, and we have also some hint for longer overall survival, and the overall survival at 10 years is 70% with 6 cycles of BR. Bendamustine rituximab was calculated in many countries in the world if that is cost effective. Of course, we not only should count the treatment costs of the treatment phase 6 months, you have to treat hospitalization, antibiotics, growth factor, second-line treatment needed in the future. Very clearly, bendamustine was cost-effective. Less hematotoxic, less growth factor use, lower rate of infections, less antibiotics needed, fewer hospitalization, lower rate of relapses, less second-line treatments needed. In England, it was per cycles of bendamustine rituximab saving over 1,000 British pounds per cycle for the pharmacoeconomy of the country. Bendamustine rituximab also is having a better quality of life for the patient compared to R-CHOP. And this is here, the black bar bendamustine, the gray bar is CHOP, and in general health and quality of life, patients with bendamustine are improving, and patients with CHOP-R have a reduced quality of life, which is not a big surprise. When you have a questionnaire, you should calculate your quality of life. You see yourself in the mirror in the morning and you have no hair, probably your quality of life is very low immediately. So no wonder that they tick the box, I don't feel so happy. Otherwise, patients have had some fever with R-CHOP, they have the neuropathy, and all this is reducing quality of life. In this table, we see favoring BR, favoring CHOP. In all circumstances, BR was better, cognitive, physical, role, social, emotional, and here favoring bendamustine in most circumstances. However, appetite lost was better with CHOP, because with CHOP you get prednisone, which makes you a little bit more happy to eat. And on the other side, nausea and vomiting was better with CHOP. How comes that CHOP has less nausea than bendamustine? Because bendamustine is making a delayed nausea in 30% of the patients, and the nausea comes on day 3, 4, 5. Therefore, we need a 5-HT3 antagonist with a long half-life, and then nausea is not a problem with bendamustine. So the quality of life analysis clearly shows no hair loss, no cardiotoxicity, no neuropathy, less hematotoxicity, and therefore the patient treated with BR reported a better quality of life in most areas compared with CHOP. And this justifies again that people with a lymphoma should be treated with bendamustine. They have less side effects, they have better efficacy and better quality of life. We all know that there is a huge debate in the field if the patient has achieved with the induction treatment a response. Should we continue with maintenance? We all know the PRIMA trial where R-CHOP, RCVP patients were treated, achieved the response, and then were randomized to observation or rituximab 2 years. This was the result in terms of progression-free survival. Rituximab maintenance showed a better disease control than no maintenance. In the overall survival, we have seen no difference. So typically, the typical answer would be, it is too short follow-up to see an overall survival. But when you see a 6-year follow-up, the progression-free survival is better for maintenance, but unfortunately, still you have the same overall survival for the patients treated with 2 years or no maintenance. So therefore, it is a very interesting debate if really maintenance is needed when you treat 2 years and you achieve no overall survival difference. To conclude, BR was superior to R-CHOP. However, in both arms, no maintenance was given. The PRIMA result showed maintenance, a better progression-free survival after CHOP, but no better survival. So there is one important question for all countries in the world. Should we give maintenance after BR? We can make extrapolation of the PRIMA trial, but also you have to find out if you want to have a better disease control or a longer overall survival. So I just presented at ASH 2017, so 1 month ago, the very important trial from my study group where we addressed exactly that question. Bendamustine rituximab followed by maintenance. Is maintenance meaningful? Yes or no? This is the result. This is the old study, bendamustine rituximab. This is a new study, bendamustine rituximab plus maintenance. A great benefit in terms of progression-free survival. But when you look to the overall survival, again, no difference. So the debate is open. What is the role of maintenance? And I can tell you, when I was presenting this trial in front of 3,000 people at the ASH meeting, after the presentation, people came in front and you speak with a referent and with the speakers and you make some short discussion. And the very famous American lymphoma expert came to me and he said, "Congratulations, I already know rituximab maintenance is so good even after bendamustine rituximab." And then the next expert was standing next to him. He said, "Wait a minute, I want to say congratulations, Dr. Rummel. You showed very nicely that rituximab maintenance is stupid. We do not need it." This is two perspectives of the same problem. Are you a believer of the progression-free survival or overall survival? So we have both results. I'll let it open maybe for the discussion. This is a result. Rituximab maintenance can prolong disease control, but does not translate into an overall survival. So what is a pro for bendamustine rituximab? Just to follow, Brett Carl, American key investigator, shown on ASCO 2017, he made a review in ASH, how shall we treat follicular lymphoma? This is not my slide. This is a slide of a US American hematologist. Pro bendamustine, no hair loss, no neuropathy, no steroids, safe anthracyclines, longer progression-free survival, longer time to next treatment, less second-line treatments, no need for maintenance rituximab. What is a pro for CHOP? A little bit disappointing. Only 2 things. Less gastrointestinal toxicity because of the nausea, but I already made the comment, if you give a long-lasting 5-HT3, there is no problem. Second, less skin rash. Yes, some patients have a skin rash, but it's never a severe problem. It is just a skin rash, and you can continue with the treatment. So, Brett Carl concluded at the last ASCO meeting, bendamustine is a perfectly reasonable standard for follicular lymphoma because no maintenance is needed. R-CHOP should be given with rituximab maintenance, which is by far more expensive in terms of pharmacoeconomical costs, and it was acceptable to him because he still knows that some people are doing it. I want to conclude my talk with giving you 2 more slides where I just want to focus that bendamustine is not only good for follicular lymphoma, but also can be used in different lymphoma disease. I showed you the results for follicular lymphoma. Also, bendamustine as monotherapy or with rituximab is a perfect treatment for chronic lymphocytic leukemia. Bendamustine is a very active compound in multiple myeloma. Lymphoma I already showed you. I will show you next mantle cell lymphoma, but also what is very important in patients with Hodgkin's disease. When you have treated first line with ABVD and the patient has a relapse, bendamustine is very active in Hodgkin. Diffuse large B-cell lymphoma, it can be given in relapsed, and this is a very interesting option using bendamustine in stem cell transplantation when you use the conditioning regimen BEAM. Then you replace the B, which is BCNU, by bendamustine, which is again, from the pharmacoeconomically cost by far less expensive than BCNU, and it is published that bendamustine is a very active treatment. So in my last slide, I would like to show low-grade CLL, diffuse large B-cell, Hodgkin, mantle cell, and multiple myeloma. And I would like to conclude what is the standard of care in patients with follicular lymphoma. Watch and wait in asymptomatic patients. Bendamustine plus rituximab as a preferred treatment as recommended in the NCCN guidelines. Maintenance is an option, but did not translate into overall survival. Obinutuzumab, as shown by Dr. Lothar Böning, can be combined with bendamustine and was very effective in rituximab relapsed patients. No relevant role for high-dose treatment, and all the new compounds like idelalisib, ibrutinib, lenalidomide, bortezomib, venetoclax have not found the role in low-grade lymphoma. Ibrutinib is used in CLL and mantle cell, but for follicular lymphoma, the best choice is bendamustine rituximab. With that, I would like to thank you very much for your attention so far.
Thank you so much, Professor Ramel, for your insightful effect on the bendamustine. Let's hear another applause for Professor Ramel. And please take a seat at the most right-hand seat here. Now we will proceed to a scientific discussion moderated by Professor Ari Haryanto. Professor Ari will also deliver a presentation entitled On the Pursuit of a Better Lymphoma Therapy. Accompanying him today is Dr. Hilman Tajuddin, who will speak on the lymphoma cases in Indonesia. Following his presentation, Professor Ramel will come back, present recent advances in the treatment of non-Hodgkin lymphoma. Professor Dr. Ari Haryanto, Reksodi Putra SPPD Kahom, is the head of the National Coordinative and Cooperative Board of Hematology and Medical Oncology. He is also the chairman of the Indonesian Society of Hematology and Medical Oncology, or it's known as Perhompedin. He is also an expert in the multi-center epidemiology and survival study of B-cell non-Hodgkin lymphoma patients in Indonesia. Dr. Hilman Tajuddin, SPPD Kahom, is the Chief of Society of Hematology and Blood Transfusion in Indonesia, or as we know as PHTDI. He is also the Chief of Educational Coordination Committee, as well as the Chief of Hematology Oncology Division at the Dharma East Cancer Hospital. Prof. Ari, please come to the stage as a speaker moderator, followed by Dr. Hilman.
Well, good morning, everybody. It's really an honor for me to moderate these two speakers. Well, I'd like to thank Ferron for this nice example. Medical oncology is a relatively young specialty in Indonesia. All medical oncologists now are hematologists. They were hematologists. And because in 1991, when we make the Cancer Center Hospital, we developed medical oncology. So it's only from, say, 1991 or 1993. In fact. So many problems is with us. As you have seen already, cancer is a really systemic disease. It's not a topical disease, it's really systemic. From our late patient, Mr. Soetikno, we know that the change to bendamustine was also based on his age and his cardiac condition. So it's very important to take into consideration other organs. And then we see how Mr. Soetikno, late Mr. Soetikno, developed renal insufficiency. So without knowing internal medicine, the patient would be in good condition like that, even may not survive perhaps. So that's very important. And then we also see from what the discussion were that the survival, etc., survival and difference between survival and disease-free of survival, where we see that also disease-free or progression-free survival is better, but survival is the same. Why? Because of the condition of the patient, even they have some illness, some tumors, they still have a good quality of life. So quality of life is very important. Take into consideration of the systemic disease, the organ, the condition, the age, side effects of the drugs. Age, side effects of drugs, then symptoms caused by the cancer. Cancer causes metabolic abnormality. Cancer causes immune deficiency. Cancer causes thrombosis. And most of the patients died not because of cancer, they died because of an infection or thrombosis. So that's why other organs like heart disease, heart problems, lung problems are playing very important. We'll see from this is what we very appreciate of this meeting, especially after this meeting, Professor Rummel will be talking again. So we can really realize how a medical oncologist should work, how they have to take care, consider the systemic systems. It's the human, the whole system, not the side effect of the drugs, function of the organs, comorbid, age, etc. So this will be discussed in the coming session. First, we'll hear from Dr. Hillman, our experience of lymphoma. Lymphoma is one of the number 6 cancer in Indonesia, and it's a very good example for oncologists to learn lymphoma before they treat solid tumors, because this is a hematologic solid tumor and it has caused a lot of side effects. So this is a kind of cancer which plays an important role for the management of cancer in solid tumors. And after that, we'll hear from Professor Rummel, of course, how cancer now has developed very aggressively. Cancer now is becoming a very, the role of molecular biology is becoming more and more important now. And we'll see how cancer subtypes develop because of the development of molecular biology. What is the consequence? The consequence is that the treatment will change not only from cytostatics, but also to targeted treatment, targeted to the proteins, which is developed by molecular biology, and this will be very expensive. From there, we know how cost-effective is very important, how many things has to be considered by a doctor giving treatment, how to begin, which cytostatic to give, and when to stop, even to stop, you see? And if you continue giving treatment to the patient just to achieve progression-free, you'll use a lot of money. And cost-effective is one of the most important things in our country. In a country like us, where we are still very young relatively, where financial is a problem, cost-effective is very important. So the role of a person who's giving chemotherapy should really understand internal medicine. That's why in medical oncologist study, they have 40% medical internal medicine, 40% oncology, and 2% research. Research is very important because everybody, medical oncologist, has to be updated with the commencement of scientific now. So they have really to have to understand how to interpret the results, like what has been shown by Professor Rummel. Well, we'll begin now, because I think may I invite Dr. Hillman for your lecture. Thank you very much. Please, yes.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera untuk kita semua. Yang terhormat Profesor Ari, terima kasih untuk kata pendahuluan Profesor Rummel, Dr. Benning, and his wife, Pak Ferry, para kolega, para senior yang saya hormati. Terima kasih untuk kehadirannya. Kali ini saya diberikan mandat oleh Prof. Ari untuk membawakan makalah beliau sebetulnya yang berjudul Multi-Center Epidemiology and Survival Study of B-cell non-Hodgkin lymphoma in Patient in Indonesia. Saya akan membawakan dalam bahasa Inggris. As we know that diffuse large B-cell lymphoma is the most common lymphoma in the world. Since this disease is very, very devastating and also catastrophic. And also, as we know also, this is heterogeneous in clinical characteristics. 40% of the patients will take advantage for the response and also prolong survival to current therapy, but the rest of them remain succumb for the disease. There are some diversity of lymphoma patients. As mentioned by Professor Rummel, which is an expert of follicular lymphoma, there are patients with germinal central B-like DLBCLs have a significantly better overall survival than ABC1. Then, at the time, Professor Ari, the aims of Professor Ari study is to get a national epidemiology data of B-cells non-Hodgkin lymphoma patient in Indonesia. As methods, Professor Ari mentioned that there are multi-center cross-sectional study on patients diagnosed as non-Hodgkin lymphoma. And he recruited 13 hematology centers in Indonesia, which I will describe later on. The data has already collected consists of non-Hodgkin histological diagnosis, patient and clinical characteristic, type of treatment, EP index, international prognostic index, and also the treatment response. And also, last but not least, the histological review was done in each center based on morphology and also immunostaining. Every pathologist in the center received the case accession, which was performed by the clinician counterpart. And there was also a system, a reference system was applied for pathology review. And it was collected based on regional area and the facilities available. The second line centers referred their own specimen as well as the referring specimen, and also the third line center review its own referred specimen for subtyping. So there's a difference between second line, the second line centers and also the third line. And finally, the second line center reviewed all cases reported from all centers. And also there are some antibodies used at this research. Treatment response were analyzed in a group of patients who got 4 cycles, at least 4 cycles or more, with or without radiotherapy. And estimation of survival analysis were calculated according to Kaplan-Meier survival analysis. At the time, Professor Ori also reported about 50 consecutive patients who were diagnosed as B cells NHL, treated at our National Cancer Center, Darmais, what I mean, one of our hematology center included in this multi-center study. As a result, 200 consecutive non-Hodgkin lymphoma from November 2008 until July 2010 was collected. Among them, 164 patients were diagnosed as B cells NHL. And if 55% of patients were male, and the median age was 41, and the educational background we will describe later on, which was from senior high school and also about the college graduated. This is a table about the hematology center in Indonesia, which was already collected from Medan over there, and also Palembang, Jakarta, and also last but not least is in Manado. And the amount of the patients already described. And what about the characteristics of the patients? There are some items of characteristics from sex, and on a group of age, race, educational background, occupational types, and exposure. As we know, we knew finally that manure is play a role as for the full infiltration of non-Hodgkin lymphoma. And 42% patients got some exposure, as I mentioned, from cigarettes, ultraviolets, manure. Manure is, the value of manure is 11.9%. And according to the study, the most of the patients had weight of loss and fever as a chief complaint, and also there's a bulging at the neck, and also the inguinal and abdominal nodes involved. And also as a comorbidity, there's a hypertension, diabetes, and tuberculosis. We'll take a look at the table number 3. This is a clinical characteristic of the patients from symptomatic fever, weight of loss, pain, and on comorbidity, disease, tumor and location, while their involvement, stage of disease, and ECOG performance. And about 35% of the patients has stage 2. We will see later on. 28% of patients were stage 1, and 27% of the patients were at stage 3. Stage 4, only 9%. And only 1%, 1.4% exactly, patients had ECOG score 4, while 77.7% had ECOG score of 0 or 1. And based on histologic type of B cells non-Hodgkin lymphoma, we found that 68.2% of Indonesian NHL were suffering from DLBCL. We'll look at this one. Well, comparing to the Caucasian literature, the value of DLBCL is around 30 to 40%. But for our society, for our population, it's a very, very more than that. Follicular lymphoma in the other sites is 10%. And there's also another portion of, small portion, what I mean is small cell lymphoma, and then also MALT, and then mantle cell lymphoma. Yes, as mentioned, the other commonest of NHL, follicular lymphoma, 10%. Yes, as I mentioned before, that one of our hematology center, Darmais Cancer Center, we found that there are 74% of NHL treated at the Darmais Cancer Center, which commonest gender was female. The value is 54%, and the age is more or between 40 to 60 years of old. And 40% of these patients had weight loss, and also there's a bulging at the neck and the other sides. And also for the EP score, the most of the patients had score of low or a low risk. And this is the characteristic of Darmais Cancer Center. And this is the items: phone age, stage, LDA serum, external nodal, ECOG, and EP score. I'd like to continue with our Darmais data. Among of 50 patients were reported of 36 patients who decided to continue the treatment. But between them, while only 28% treatment group analyzed for treatment. And a complete remission was achieved in 19 patients, which stands for 67.9%. And the others achieved only partial response. 2 patients unfortunately passed away at the time during the chemotherapy regimen, and 4 patients were in stable or progressive disease. And based on chemotherapy regimen, there is some chemotherapy. CHOP regimen at the time was the most applied chemotherapy, and another regimen COP, DHAP, or other combinations. And we continue collecting data from 2011 until 2016. We have already collected some other patients. Then this is the amount of newly diagnosed non-Hodgkin lymphoma, and also some of them are dropped out in period of 2011 and 2016, from 2011 and 2016. Well, we want to know further for what kind of reasons those patients are dropped out. Then explanation is just like this: pass away, therapy in other hospital because one of other reasons, a side effect of chemotherapy, and personal reasons, maybe they want to seek for another cancer center, second opinion, and then could be contacted. Most of them couldn't be contacted also. And this is the pie diagram of reason of patients who dropped out in period of 2011 and 2016. As I mentioned, passed away, therapy in other hospital, couldn't be contacted. And for the explanation of personal reasons, is patient reviews for having chemotherapy. Maybe they very, very tired at the time, cost issue, because some of the drugs takes lots of money, and the patient feeling unwell because of chemotherapy. But the other reasons is patient didn't have any time to control. I think for me, this is my last slides. Thank you so much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Hilman. Please take your seat. Well, we now go to our next speaker, Professor Romo, who's going to discuss about non-Hodgkin lymphoma. Thank you very much.
So I would like to continue now with 2 lectures about one mantle cell lymphoma, and the second, this is the last one, is very important because we already heard diffuse large B-cell lymphoma is the most often seen lymphoma disease, not only in Indonesia, but also in the world. It's the most common lymphoma. So I would like to start with the mantle cell lymphoma. I would like to show you the current treatment strategies. Computer must be connected. I already made the comment before, if somebody asked me if my slides are working, I also can talk without slides, but it's better with slides. Yes, here they are. So mantle cell lymphoma, and in mantle cell lymphoma we have now it's working. We have some categories, because in mantle cell lymphoma we have two classes of patients: the young patients who can tolerate aggressive treatment, and the elderly patients who cannot tolerate such intensive treatment, because the mantle cell lymphoma is a disease with a very poor outcome. Therefore, we should consider some more aggressive treatments. So for younger patients, it should include high-dose RSC, rituximab followed by stem cell transplantation, and for the elderly patients, bendamustine is the backbone of treatment. This is very clear, the consensus all over the world. Another role you see here for bendamustine. The elderly patients with mantle cell lymphoma should be treated with a bendamustine as backbone. And then, of course, we have some new treatments like the ibrutinib, bortezomib, and lenalidomide. I would like to show you for the young patients two trials, very important. The one is from Scandinavian countries. It is called the Nordic Lymphoma Group. And they treated with a treatment CHOP and added high-dose RSC and rituximab. These are the results. The old trial was CHOP, followed by stem cell transplantation. The new trial from 2006 was CHOP in between high-dose RSC and rituximab, followed by stem cell transplantation. High-dose RSC is 3 grams per meter square, 4 infusions per cycle. For patients above 60, it was 2 grams per meter square. So this is really high-dose RSC. These are the results compared to only CHOP. Here, the progression-free survival and the overall survival was improved. And the long-term overall survival shows the longest outcome for patients reported with mantle cell lymphoma, a median overall survival of nearly 13 years. This is the best result reported in the literature, showing high-dose RSC is important for young patients with mantle cell lymphoma. The French trial just recently reported the role of rituximab maintenance after stem cell transplantation in young patients with mantle cell lymphoma. They treated 4 cycles RDHAP, which includes high-dose RSC, followed by stem cell transplantation, and then randomized observation or maintenance. So the question was, is maintenance improving this aggressive treatment strategy? Yes, it did. You see here the red curve. Rituximab is having a better progression-free survival, statistically significant, and also this did translate into a statistically significant better overall survival. Of note, at 4 years, 48 months, the overall survival was 88% with rituximab maintenance, without maintenance 81%. Just remember this number of patients alive at 4 years when I will show you later some results for bendamustine. Conclusion was rituximab maintenance should be given for young patients who went into a transplantation. As mentioned before, bendamustine plays an important role in patients with mantle cell lymphoma when they have comorbidity or are too old for high-dose RSC. And again, we were the one who did the study. This is again the STEEL trial, and it was for mantle cell lymphoma the very first time showing bendamustine rituximab was superior to R-CHOP even in the aggressive lymphoma, which is the mantle cell lymphoma. This result were later on confirmed by American trial, and the American trial called the BRIGHT trial compared bendamustine rituximab against R-CHOP against R-CVP. So complete response rate for patients with mantle cell lymphoma were 51% with BR, 30% and 14% only with the comparator. And this again translated into an improved progression-free survival for patients treated with BR compared to CHOP-R. How further can BR be improved? And here comes again Ara-C, as I told you, is a very important key medication in mantle cell lymphoma. However, in elderly patients, you cannot administer 3 grams per meter square. Therefore, this study very nicely showed Ara-C with 500 milligrams per meter square on 3 days can be combined with bendamustine, and with that bendamustine was reduced from 90 to 70. So this is an attempt to further improve BR by the addition of Ara-C. Patient characteristics, 71-year-old, so the typical patient who cannot tolerate stem cell transplantation. The cytopenia was a little bit a problem because when you give Ara-C, you will finally see thrombocytopenia. Ara-C is very hematotoxic, which is known from all acute leukemia protocols. So thrombocytopenia was not a surprise. But what was a surprise? The very high complete response rate with bendamustine rituximab and Ara-C called the RBEC regimen. With PET-CT, 93% achieved a PET-CT negative complete response rate. Unbelievable high response rate never seen before in elderly patients with mantle cell lymphoma. This is a survival curve for progression-free and overall survival, and really it influenced the treatment guidelines again. RBEC 500, bendamustine, Ara-C with a dose of 500 is a very effective treatment for patients with mantle cell lymphoma. So it was out in all international countries. Bendamustine rituximab was a big surprise that it was so active in mantle cell lymphoma. And interestingly, the American colleagues compared bendamustine rituximab against R-hypercivet. That is here, R-hypercivet, a really interesting comparison. Just imagine, randomization, BR or R-hypercivet. What a huge different treatment strategy. And the Americans colleague did it. So they treated R-hypercivet, high-dose Ara-C, methotrexate, stem cell collection, went to transplantation, or the other arm only received BR, followed by stem cell collection, went to transplantation. This is for younger patients an attempt to find out how good is BR compared to the most aggressive treatment available, which is R-hypercivet. The people feared that maybe you cannot collect stem cells after bendamustine, maybe, nobody knows. So they said either arm would be unacceptable if stem cell collection failure is higher than 10%. And what happened? The stem cell collection failure was high in R-hypercivet, 5 patients out of 17. But out of 35 patients BR, only 2 patients could not collect stem cells. A big surprise to the community. It was a problem with R-hypercivet, but not with BR. Therefore, the study was stopped early because this is a stopping signal. And of note, BR had the same progression-free survival in this small study as R-hyper-CVAD and the same overall survival. What an interesting result, considering that R-hyper-CVAD is really the most aggressive treatment available in patients with mantle cell lymphoma. Also in this study, there was done minimal residual disease with next-generation sequencing and DNA extracted liquid biopsy, and they found out 8 of 9 patients with bendamustine became MRD negative, again showing that the quality of response after BR is really very good. So the American Congress concluded R-hyper-CVAD is not an ideal platform for building next trials in mantle cell lymphoma. B-arm achieved an 89% MRD negative rate and therefore should be the future platform for next clinical trials. And this really is a huge surprise for the international community that this study is challenging the R-hyper-CVAD. Of course, the story goes on, and there are much more trials in the international community with the backbone of bendamustine. It could be given with maintenance, with bortezomib, with cytarabine, with lenalidomide, and of course with ibrutinib. We did the study in our center, mantle cell bendamustine watch and wait against bendamustine rituximab plus 2 years. We presented half a year ago in Chicago at the ASCO meeting. Patient characteristics, 70 years old, so patients who could not go to transplantation. The overall response rate was 85%, and this is the progression-free survival of all patients, 43 months with BR, and this is the progression-free survival of the rituximab maintenance. You can see that there is no statistically significant difference between bendamustine rituximab alone and bendamustine rituximab and maintenance. Of further importance, the overall survival shows this picture. But this is interesting because, for the one hand, it is not statistically significant difference. However, the blue curve with maintenance is below the red curve, which is no maintenance. It is not very much different, but you see, maintenance again did not translate into a better survival, even it was a little bit inferior, despite the fact that this is not statistically significant difference. And now, this is the number. What is the rate of patients alive after 4 years with bendamustine rituximab alone? 85%. Remember the French study with transplantation and maintenance, the most aggressive treatment for young patients. The overall survival at 4 years was 81 or 88%. Again, with bendamustine rituximab, you are in the same treatment corridor as the aggressive treatment I showed you. And of course, when we talk about mantle cell lymphoma, we should not forget to mention ibrutinib. This is one of the targeted treatment Professor Ari already has mentioned, a very targeted treatment taken as a tablet every day continuously. It cannot cure the disease, it just controls the disease by continuous treatment, and of course it was used first time in patients who are heavily pretreated. Median 3 prior treatments, 50% nearly are refractory. And you give ibrutinib 4 tablets a day, and the overall response rate was 68%, and this was a really great response rate in patients who are refractory to 3 prior treatment lines. Therefore, ibrutinib has a definite role in relapsed patients with mantle cell lymphoma. And of course, how to further improve it, bendamustine rituximab again plays a role because it is the backbone of this trial bendamustine rituximab plus placebo against bendamustine rituximab plus ibrutinib. This is worldwide registration study showing if the addition of ibrutinib will improve the survival, but the interesting message is BR is in both arms the backbone. So bendamustine rituximab is absolutely established in the treatment of patients with mantle cell lymphoma. Therefore, I conclude my talk for mantle cell lymphoma. Survival is improved, but still the mantle cell lymphoma is considered to be a non-curative disease. Why we have achieved treatment improvement? Because of high-dose cytarabine, stem cell transplantation for younger patients, and bendamustine implementation for elderly patients not candidates for stem cell transplantation. Bendamustine plus rituximab is the treatment for patients not eligible for high dose, and it can be further improved by adding cytarabine. The new compounds like ibrutinib, bortezomib, lenalidomide are available, and ibrutinib is the one agent with the most promising activity for the future. With that, I would like to change to my last slide and report. This is the aggressive lymphoma, which is also in your country the most common disease. Aggressive lymphoma, which is called diffuse large B-cell lymphoma. I would like to show you what was the major step in the history of diffuse large B-cell lymphoma and how we should treat this disease today. This is the NCCN guidelines. And we see here treatment, first line is R-CHOP. Dose stands R-CHOP 14 and dose adjusted epoch. This is R-CHOP every 21 days, R-CHOP every 14 days, and dose adjusted epoch. Very important is to see this is category 1, this is category 3, and this is category 2B. That means evidence level. The best evidence is for R-CHOP, and I would like to show you the results. What is the European guideline telling us? The European guidelines also say R-CHOP 21. However, we have here in Europe RACVBP, and I would like to introduce this regimen to you. It is made by Europeans, and maybe that's the reason why the NCCN guidelines have not listed it. So the question, typically, when you would have an answering machine, I could ask you that question. The next 45-year-old patient with diffuse large B-cell lymphoma, ECOG 0, stage 4A, high LDH, what would be the treatment? CHOP R14, CHOP R21, CHOP with etoposide, dose-adjusted epoch, the European regimen ACVBP, or immediately stem cell transplantation. Probably when I ask this question, you get many different answers because there is a piece of information for that and another piece of information for that, and I will show you in the next slides what is the answer. And also, a very critical question is that, how many cycles are you giving? Is that an important question? How many cycles? Absolutely. It is such a big difference if you give 6 times CHOP or 8 times CHOP. If you ever give 8 times, you need to have evidence that 8 cycles are better than 6. So how many cycles are you giving? 6 R-CHOP 21, 8 times R-CHOP 21, or 6 times R-CHOP 14, or 6 times R-CHOP 21 plus 2 additional rituximab. And I can tell you, all people in North America give 8 cycles R-CHOP 21, and all people in the rest of the world give 6 cycles R-CHOP 21. And I'm convinced that this is the best approach. 6 times R-CHOP 21 plus 2 additional rituximab. What have we learned from the past? This is the most important paper, 1990, in the New England Journal of Medicine, very long time ago. First time it was demonstrated. CHOP is the first treatment found which can cure an aggressive lymphoma. Once you found that CHOP can cure the disease, all clinicians around the world try to improve CHOP. What you do, you are taking some more medications to it. CHOP, first generation, COPA, BARCOP, MOP, second generation, COP, BLAM, M, BARCOT, third generation, you ask the pharmacy, please give me everything what is available. I want to give everything to the patient. And this is pro-Cytobom. This have much higher response rates. But is that the better treatment? And Fisher from America showed this famous paper, which should be an education for all of us. Don't believe in just more intensity. We need to have evidence. Pro-Cytobom and CHOP is all the same in terms of overall survival. This is showing that we need randomized trials before we can conclude what is the best trial. Having this in mind, 1993, what was the next step? The next step was the addition of rituximab. Rituximab, 2002, again in the New England Journal. CHOP against CHOP rituximab. And this was the first time that the overall survival was improved by the addition of rituximab. Today, R-CHOP is the standard of care. How often and how fast you can give it? There were some study groups in Germany and in other countries. When you hit the cancer cell much more faster, maybe you can kill it faster. So why not give R-CHOP 14 instead of R-CHOP 21? And then, of course, somebody has to do a randomized trial. This was done in the Gela, France, 8 times R-CHOP 21 against CHOP 14, and in England, 540 patients, R-CHOP 21, R-CHOP 14. This is the result. There is zero difference in progression-free survival and zero difference in overall survival. That is clearly the conclusion. R-CHOP 14 is not the best treatment. R-CHOP 21 is the standard. And here is a French regimen, RACVBP. And they had 4 cycles of RACVBP, which is an intensified CHOP, followed by 2 cycles methotrexate, 2 cycles ifosfamide VP16s, and 2 cycles RAC, which in the end is a much longer treatment. And this is the only trial after R-CHOP which improved the overall survival. This is disease-free and this is overall survival. The only study available in the literature where a treatment is better than R-CHOP. But what is the reason that not too many countries are using RACVBP? Because toxicity with RACVBP is much higher. Even here, mucositis and infection and neurology is much higher. However, when I see my next young patient in the age of 28 or 35 or 42, 100% fit and highly motivated, I will do RACVBP because this really has a higher rate of cure. The standard patient will get R-CHOP 21 because this is routine in my clinic. RACVBP is quite challenging also for the treating physicians and for the treating nurses because of the high rate of side effects. The conclusion was RACVBP should be the standard of care for younger patients with diffuse large B-cell lymphoma. Though this is where we are today. We came from this old New England Journal paper, Cytobom, MBARCOT, CHOP. CHOP was a standard. CHOP versus R-CHOP. R-CHOP is a standard. CHOP 21 against CHOP 14. 14 is not superior. And then this next study is R-CHOP against dose-adjusted epoch. And here the addition of etoposide was not very convincing, but these are the next three trials. R-CHOP plus bortezomib against R-CHOP, R-CHOP plus ibrutinib against R-CHOP, and R-CHOP plus Revlimid, which is lenalidomide, against R-CHOP. And these three new agents are added to R-CHOP to further improve what Dr. Hillman has mentioned, the ABC-type lymphoma, which is more aggressive. We don't know the results of these three trials. We don't know if bortezomib, ibrutinib, or lenalidomide will improve the results of R-CHOP. What we know is dose-adjusted epoch against R-CHOP. Dose-adjusted epoch is the R-CHOP regimen giving as continuous infusion over 96 hours. This is 4 days continuous infusion over a central venous catheter, and the patient needs to be hospitalized for that. So it's a huge effort. Is it better than R-CHOP? Many people said yes, but then we have a randomized trial presented 1 year ago at the ASH meeting. Dose-adjusted epoch against R-CHOP. And it was clearly the aim to show that dose-adjusted epoch is better. Unfortunately, this is the result. Event-free survival and overall survival again was the same. So you know already what was the conclusion. R-CHOP 21 is a standard. Even dose-adjusted epoch could not improve the results. And then there was the first attempt with lenalidomide, the REMARK study. The REMARK study treated all patients with R-CHOP and then did a random maintenance with lenalidomide. Lenalidomide, what is the role of it? And they did it like this. Everybody was treated with R-CHOP and then randomized lenalidomide maintenance against no maintenance, which is a standard. Very interesting results, because the red curve, lenalidomide, shows a better progression-free survival with a p-value of 0.01. The very first time that a new compound like lenalidomide did improve one outcome. However, we see here the overall survival. And the overall survival is not only not different, but the red curve with lenalidomide is below the other curve. How comes that you have a treatment which has a better progression-free survival and a poorer survival? Because lenalidomide is so toxic, 56% neutropenia, and so the better disease control translated into a reduced survival. What a big surprise, and therefore, of course, R-CHOP remains the standard. Again, lenalidomide did not change the outcome. And then, this was the biggest study with the biggest hope, because everybody knows rituximab is in the field for 20 years. Everybody hopes there will be a new antibody, and the company Roche and Genentech have developed the new type 2 antibody, obinutuzumab. So it was clearly the randomized trial, rituximab CHOP against obinutuzumab CHOP. What is a better treatment? And we have to pay attention. Obinutuzumab in combination with chemo should be tested in every disease, and we cannot extrapolate. So we need to find out, is it better in follicular? It is better in mantle cell? Is it better in diffuse large B-cell? And this is a Goya study for diffuse large B-cell lymphoma. Very big disappointment for all clinicians and for the company Roche. obinutuzumab was not better than rituximab in terms of progression-free survival and in terms of overall survival. Again, you really cannot see that these are two curves. It's absolutely superimposable. Obinutuzumab did not make a difference. By the way, a comment is obinutuzumab is a very effective treatment in chronic lymphocytic leukemia. It has some effect, as Dr. Lothar Böning showed, in follicular lymphoma, and it has zero effect in aggressive lymphoma. Therefore, R-CHOP remains the standard. Before I conclude, I would like to show you when R-CHOP is not the standard. Of course, we have aggressive lymphomas where R-CHOP is not the best treatment. And I put this in the slide when R-CHOP is not appropriate. Of course, we should not treat Burkitt lymphoma with R-CHOP. We treat it like an acute lymphoblastic leukemia. When you have a primary mediastinal B-cell lymphoma, we have learned that this disease in the mediastinum is very similar to Hodgkin's disease. Primary mediastinal B-cell lymphoma should be treated with dose-adjusted EPOCH-R because there is a New England Journal paper for this special disease. Unfavorable risk groups, and I put here a question mark. This is my statement. In young patient with an advanced lymphoma, I will try to make RACVBP. What are we doing with peripheral T-cell lymphoma? This is different because here in T-cell, rituximab does not play a role. We add etoposide to the CHOP regimen, which is CHOEP. Central nervous lymphoma disease, we need high-dose methotrexate, high-dose Ara-C, and R-CHOP is not active in CNS lymphoma. What are we doing in elderly patient? When you have an 80-year-old patient with a diffuse large B-cell lymphoma and with some low ejection fraction of the heart, can you administer R-CHOP? I would not. Therefore, we have here in the frail and elderly patients two options, bendamustine rituximab or mini-CHOP. Mini-CHOP means 50% dose reduction of the CHOP. And patient with a low ejection fraction, we can give CEOP, which is not having an anthracycline, or BR. And when patients relapse after CHOP-R and they are not candidates for stem cell transplantation, I give in my clinic bendamustine rituximab and in some circumstances Ara-C. With that, I hope that I have shown you the most important key studies in diffuse large and mantle cell lymphomas to give you an update what is done in international community for treating patients with diffuse large B-cell and mantle cell lymphoma. I thank you very much for your attention, and I hope that we have a fruitful discussion.
Thank you very much. Thank you very much, Father. Well, we have seen how very complicated you have to think about when you give chemotherapy. Not only looking at the protocol and the books, and then you entered protocol. You see how, after all, age, performance status, condition of patients are very important. And that needs, of course, a very thorough evaluation of the condition of patient, the heart patient, the performance status, the age, infection, frail, which are not so good. And we see that in some cases, budamestine can be added to the patient, or older patient who cannot be given high-dose Ara-C. Well, with this, I'd like to, we can open the discussion. May I have some people who want to ask questions from your floor, please? We've opened the first session. Questions from the audience? Yes, please. Please, yes. Thank you very much.
Thank you very much, Professor Mathias. Thanks for your very convinced and clear-cut presentation about a very interesting topic. I'm from Myanmar. Actually, I'm a radiation oncologist, but now we are as a professional, as a clinical oncologist, so I treat both radiation and medical oncology in my perspective. My question is regarding NK T-cell lymphoma. That is not included in the topic. I have only experienced, I have come across in 2 cases very recently. One is extranodal NK T-cell lymphocyte, and another thing is nodal lymphoma in the supracleft and in the mediastinum. So for those cases, actually not my first contact point. That is from other hemato-oncologists. And after relapse for NKT cell, so first I treat with the radiation, and almost all the cases are relapsed after two weeks after that. That is proliferative index is very, very high. So I give the treatment with chemo with VIP, VIVE regimes and SMILE regimes and EPOC almost. But the patient is response very quite quickly within the introduction of the chemo, 1 or 2 days, but reappear after 10 days. So relapse is very, very frequently and rapidly. So what is the management of the refractory of this case? And also it is response to bendamustine. Thank you.
Thank you.
So the NKT cell lymphoma is a very rare disease. It's more often in Asian countries than in Europe. I have seen only very few patients, but I have seen some. I always communicate with my colleague Dr. Kim in South Korea, because he is the lead investigator of many clinical trials with NKT cell lymphoma of the nasal type and the throat. The SMILE protocol is the one and only, which includes high-dose asparaginase. As far as I understand, this is the most important medication against NKT cell. Despite the SMILE protocol, many patients will relapse. After relapse, we have no clear recommendation, because allogeneic autologous stem cell transplantation did not influence. Radiation would be one factor to control the disease. But interestingly, very recently, some investigators have reported that PD-1 blockade is the most active treatment for relapsed patients. It is, of course, not approved. It is fully off-label, but you cannot expect approval because it's such a rare disease. But in case I have a patient with relapsed disease, I would try to organize PD-1 treatment in relapsed disease.
Yes, please. Still have some other question.
For NKT cell desert type lymphoma, in my center we don't have a stem cell transplant. I would like to ask that, is there any role of the cranial prophylaxis for NKT cell nasal type lymphoma?
Of what? Of?
NKT cell nasal cell lymphoma for prophylaxis of cranial. CNS prophylaxis treatment, either intrathecal methotrexate or radiation therapy.
I think the SMILE protocol has some agents which are prophylactic for the CNS, and if you ever want to consider prophylaxis, intrathecal is not sufficient. Intrathecal is not working, because you just give a small injection here. How can you reach the whole brain? If ever, you need high-dose methotrexate for prophylaxis, 2 grams per meter square or 1.5 grams per meter square.
That's very high.
And yes, only this is penetrating the blood-brain barrier. that small injection with intrathecally is not effective. And the SMILE protocol, in my opinion, is considering that some of the medication in the SMILE is penetrating already the blood-brain barrier and is giving you some prophylaxis. But I know that the patient with NKT cell do not die from brain, but they die from local relapses and widespread disease.
Can I ask you again? Perhaps a very good example from our colleague. But one of the most important things, if we consider treatment, we have to think also, of course, of the cost-effectiveness. What shall we continue giving chemotherapy from this one to another one, or shall we stop? When do we have to stop? That's also very difficult. So, like you give chemotherapy, but it relapses after the patient relapses a very, very short time. Shall we try again, and when do we have to stop? Because in once the patient perhaps or the relative of the patient sometimes he asks you to continue giving everything maximally, and but we know very well that it won't result, and we have to say to the patient one time we have to stop, because especially when we use from the government or from the so. Can you also explain to us, you mentioned also many times that performance status of the patient, the condition of the patients. What do you consider first? When do you, can you tell when do we have to start? It's a very important time for a doctor to say, this has to be stopped. And you have to tell the patient, you have no hope, you better go home, and we give palliative treatment so that they can die near the families, and they can also still maintain their financial condition. And we give palliative treatment. When do you, what are the criteria you use? I think most of us think you have to do that.
So I don't take the ECOG and performance status and not the age. I take the chemotherapy sensibility or refractory status of the patient. If a patient with a diffuse large B-cell lymphoma does not at all respond to 3 or 4 cycles R-CHOP, his chance to survive is very, very low. You can do whatever you want to, because the disease is chemotherapy refractory. In such a situation, we have to consider to say, unfortunately, we cannot achieve a cure of the disease, and we have to go for a palliative treatment. The attempt to continue with high-dose treatment and stem cell transplantation only gives a hope for a very, very small minority of the patients in that situation. Personally, always when I see a patient not responding to 3 cycles R-CHOP, unfortunately, the patient has died of the lymphoma in the next month. So this is the moment where I will not continue with all my convincement for further treatment, because a further treatment will be further toxicity and further reduced of quality of life, but not a prolonged life. So I would say it's this responsiveness to the treatment which should guide our further treatment strategy.
Thank you very much. Yes. And ECOG, how much ECOG do you say? Not age, but the ECOG 2 or 1 or?
ECOG is dependent. If the patient has a poor ECOG because of the lymphoma, you should treat with full dose. If he has a poor ECOG because of comorbidity, heart disease, kidney disease, a stroke, and a coronary heart disease and a diabetes, and he has a poor ECOG, this is different. But when he is very frail for 8 weeks in the bed because he suffers from lymphoma, I will treat him with full dose of R-CHOP immediately. And I have seen patients who nearly were dying, laying in the bed for 6 weeks. Suddenly we found it's a lymphoma. You give him 1 cycle R-CHOP, and 2 weeks later he stands up and he is alive. So it's not just the ECOG, it has to depend why the ECOG is bad.
Thank you very much. So it's very important for us. I think these are the problems which should be considered by our doctors here in Asia, where we have a shortage of financial for chemotherapy, and there's also possibility for target therapy will be very expensive. So besides not ACOG, if you have to see what's the cause of the ACOG, and ACOG is used because of the disease, because of cytokines produced by the cancer, then you can try, but not more than several times when they are not responding. And you have to consider also the function of the organs, the other organs, the heart, renal, the lungs, etc. Isn't it? So that makes that is a good lesson for us, I think, which should be really considered by us, especially now when the government is now having difficulties for more financial for our patients. We really have to consider it. And especially what's appearing now is that we have now a targeted therapy, which is in some which is promote with no side effect. So when do you, what do you think about it? Well, how is it? Because now the young doctors, they're very interested to have target therapy, new therapy. It's very good. They guys look, doctor very clever if they can give targeted therapy. It's very expensive. But on the other hand, even the patient pay by themselves, it's useless, and it sometimes cause difficulties for the relatives. What's your comment on now the new coming of targeted therapy? You have now immunotherapy, anti-PD-L1, which is very expensive, which is promising for some cases, very good for melanoma, but not being but also being tried outside for lymphoma and for lung disease, etc. How should we consider those the literature here? Thank you.
So there are clearly situations in where the new targeted treatments can improve the survival. Absolutely. So there is a chemotherapy refractory chronic lymphocytic leukemia, which has 17p minus cytogenetic aberration. In that case, chemotherapy does not work. So I see a 55-year-old man, full in his life, dedicated to his profession and family, and then he has a 17p minus deletion in CLL. This patient will benefit from ibrutinib and not from chemo. If this patient has a 13q deletion of CLL, which is chromosome 13, then chemotherapy is the best. So we need to know which kind of disease has a benefit from the standard treatment or from ibrutinib. In the 13q deletion, chemotherapy is even better than ibrutinib. And in 17p, chemotherapy is useless, and ibrutinib is the one and only. And so we will have very clearly defined solutions for each disease. And we have to use it, choosing smart and wisely the new treatment options for only the exclusive defined treatments. And this is CLL, this is in mantle cell lymphoma when the disease has relapsed, or this is in melanoma where you really can change the survival with the PD-1 and the EGFR resistance. And there are some examples in the literature, but it clearly should be restricted to these situations. Otherwise, I feel the countries who are using it in a widespread will become very poor in terms of pharmacoeconomy. And the population will not survive longer because ibrutinib, venetoclax, idelalisib, PD-1 is not good for everybody.
Thank you very much. Your statement is very important because pharmacoeconomy should be considered really now, because the government is now sometimes trying to decide which chemo, which drug, or which targeted therapy should be allowed, and for who, and what are the criteria. So that's very important. We have to come with what are the criteria to give even to the same cancer patient.
Yes.
Yes,
So
personalized.
instead of giving ibrutinib to 100 patients with chronic lymphocytic leukemia, you should invest in a better diagnostic, like finding out the cytogenetic aberration. You do finance a little bit the diagnostic tool, cytogenetic, and then you find out only 8 patients out of 100 have a benefit from ibrutinib.
Yes.
So you save 92 patients the cost for ibrutinib because you have done the cytogenetic investigation. So therefore, diagnostic must be very precise.
Yes, so pharmacokinetic and laboratory aids should be considered. So we really have to learn a lot, and people who give chemotherapy should really be serious. Well, we have some questions through the WhatsApp. It should really shown here. Yes, can I? Yes, please. The first question, Professor Miller, was, does bendamustine rituximab regimen have potential hepatic adverse reaction for liver? Can this regimen be used in patients with hepatic impairment? Can you please visually grab it?
So it does not have hepatic adverse reaction. It never happened in my career. It is not hepatotoxic. In case you have a high bilirubin and a reduced liver function, you should reduce the dose of bendamustine by 50%. But this is only the case when you have a bilirubin above 3 milligram per liter.
Yes, thank you very much. Can I have the second question, please? Second question. Professor Rummel, non-Hodgkin lymphoma cell, Hodgkin and Hodgkin lymphoma have very different microscopic view. How could bendamustine be used in both? It is hard to believe. Please, yeah, please.
I cannot understand why this is hard to believe, because adriamycin is active against Hodgkin, ABVD, and against non-Hodgkin, because bleomycin is active against Hodgkin and non-Hodgkin, because vincristine is active against Hodgkin and non-Hodgkin, and I could continue the story. So why not bendamustine is active in both diseases? When you look to the background of Hodgkin, you know that the normal counterpart cell of Hodgkin is the B cell. So that means Hodgkin and non-Hodgkin are two different diseases, but more or less they come from the B cell. So it's not a big surprise that the medication work in both diseases. So for me, it's not a surprise that bendamustine, like cyclophosphamide, like anthracycline, is active in non-Hodgkin and in Hodgkin.
Yes, perhaps our colleague is a histologist. In histology, of course, histology of non-Hodgkin lymphoma B cell and Hodgkin disease is quite different, quite different, very different.
Yes.
But the clinical picture nearly, but you have to understand that bendamustine is a alkylating agent, and alkylating through that effect, it affects the cells, cancer cells. So perhaps because he's a histologist. But we can understand, but then it's common. It's common that alkylating agent can be used for many cancer. Cyclophosphamide is effective for nearly all kind of cancer.
Breast cancer, small cell lung cancer.
Or whatever the picture of the histology is, how the cells look. Histology look at the cells, but the disease which it produces is different. And cytostatic is working for DNA production. So in all cells, even normal cells, can die because of cycle. Well, can I have another question? The third question. Yes? Third question? Still another question? Yes. What is the consideration of using RC in treatment of tissues like lymphoma? Yes.
So when you treat after R-CHOP, you treat with R-DHAP as a second-line treatment. This comprises RC. RC is a well-established active medication for relapsed lymphoma. So why not using it in the aggressive disease when you are not can use DHAP because the patient is too old, you can use bendamustine plus Aracy. So Aracy is widely established as an active agent against non-Hodgkin lymphoma. It's very old active agent. Everybody knows it. Very affordable, very easy to pay for. It's very cheap, and it's very active. It can be given sub-Q and IV, so it's a very easy drug, and I find it a very elegant solution. So Aracy plays a role in the relapsed diffuse large B-cell lymphoma, either in the DHAP regimen or in the bendamustine plus Aracy regimen.
Yes. Well, Aracy is a high-dose Aracy has long been known as a treatment for resistant or relapse. DHAP, that's the protocol. But what was new for us that in older patients, with fragile patients, for instance, you can use, because Aracy has a lot of side effects, high-dose Aracy, you can choose to bendamustine, isn't it? Yes. So we have now another problem. We know now that bendamustine can be used in a lot of cancers, Hodgkin, non-Hodgkin, and other things. And we are looking perhaps for other kinds of cancer, perhaps in the near future. Can I have the next? Is there still another question, please? No? Oh, yes. As a clinical pharmacist, what should we inform to the patient who receive bendamustine regimen? We are.
So first, when you administer bendamustine through the veins, a peripheral vein, in around 10% of the cases, you see some inflammation like a phlebitis. That is the reason why in my clinic, every cancer patient, every chemotherapy patient gets a subclavicular port. And then you never ever see phlebitis because you give it over the port. It's also better for the patient not to find a needle at every infusion. Second, patients will have some hematotoxicity and some risk for infections as all chemotherapy, but the risk is reduced compared to R-CHOP. Third, patient can experience delayed nausea when they're staying home. So when they get the treatment on day 1 and day 2, they do not have nausea. But we should inform the patient that nausea can occur after the treatment. Otherwise, they would be very surprised. Why am I feeling sick? Chemotherapy already is gone 2 days ago. No, bendamustine makes delayed nausea on day 3, 4, 5. This happens in 50% of the patients. Next is to tell the patient that they feel fatigue and some exhaustion, also lasting for 1 week after the treatment. So if the patient is at home and he feels sleepy and he says, I have no energy, this is in 50% of the cases that some patients feel loss of energy after bendamustine rituximab. So in most patients after bendamustine rituximab, no side effects, but these 4 things can happen.
Well, very important for us. So perhaps in the experience which has been shown by Dr. Hillman, a lot of patients refuse further treatment. They stop. They just say, I don't want to continue chemotherapy. So for this, as you have mentioned, the doctor perhaps have to sit longer a little bit, give some time for the patient, explain what's going to happen to you, and what's the benefit also, and how can we do, what can we do for that. So with the risk and the benefit and explaining what's going to happen, we hope that patient will be, less patient will be dropped out.
But
here the doctors have too many patients. You see, here in the Rice Hospital, for instance, sometimes doctor has to treat 30 to 35 cancer patients per day. Cancer. It's not not the internal patient. It's a cancer. It's a cancer hospital. And cancer, 35 cancer. You imagine how many minutes can you give to one patient? So that's why I think that's why we have to arrange and think, how can we solve this problem? Who can help us to explain to patients what is going to happen and what your benefit will be? Well, Dr. Hillman perhaps have some If you want to ask some question, please.
to Professor Rumal. In my opinion, tumor microenvironments reflects tumorigenesis, plays a role, important role in follicular lymphoma. What's your opinion about this? If your country also already implemented this technique, what kind of, could you please mention what kind of technique you want to?
What was the question? See?
Tumor microenvironment.
Microenvironment.
Yes, in follicular lymphoma.
So our current study and scientific plan is to investigate the environment of follicular lymphoma, of all B-cell lymphomas, by having the lymph node biopsy, analyzing by next generation sequencing which type of tumor mutations we can find in the lymphoma tissue. If we know the individual mutation profile, we look for the same in the peripheral blood with liquid biopsies, and we look out for the cell-free DNA of the malignant cells. This is liquid biopsy. And then we follow up our patient with liquid biopsy, and at the moment we do correlation to the clinical diagnostic like CT scan, bone marrow biopsy, and PET-CT. And the plan is in the future to not need any more CT scans, bone marrow biopsies, PET-CTs, but we can trust, hopefully, if the study is positive, on the results of the liquid biopsy. This is our plan at the moment, not only our plan, also Stanford in San Francisco is doing it, and the MD Anderson is doing it. So this is the plan to find as much as possible information of each disease, the microenvironments, the mutation landscape, and to follow this in the cell-free DNA in the peripheral blood.
So you see how
sophisticated.
Yes, how microbiology, the roles a very important role in the management of cancer, and in the future it will be more and more more and more study about this, what will be the future, and you see now the people are already trying to see from peripheral blood whether you still have the disease or not, or what the prognosis will be from DNA in the peripheral. It's so far is the role of basic science in cancer. So please, our colleagues who are trying to give chemotherapy, please don't stop studying. You have to read all the time. Every day you have new things and new methods and new technology and new theory which should be considered for each patient. Do you have any other questions? There still are some questions? Yes, you still have some questions. Yes, this is, what's the biggest challenge in treating lymphoma patients in Indonesia? Does mudamustin offer significant benefit? Well, that's a question. Could you answer? You? Yes. What is for you? Yes. Yes.
What's the biggest challenge in treating lymphoma patients in Indonesia? Does mudamustin offer significant benefit? Well, actually, the question should be aimed to Professor Ari, because Professor Ari gave it. But okay, I'm trying to explain, Prof. I'm the person who responsible for this presentation. The biggest prevalence in Indonesia, well, we have some patients, as mentioned by one of my PowerPoint, 68% came from DLBCLs. It means that the characteristic of lymphoma itself, not only indolent as Professor Rumal mentioned, but also the characteristics is aggressive or very aggressive. And the therapy should be also tailored. What I mean should be also a given regimen that specific for aggressive and very aggressive chemotherapy patients. And the other things, the big challenge also we until now, we're still fighting for a transplantation, Professor Ari, which I think in European countries is not a big deal or big problems for Professor Rumo. But for us, it's a very, very big deal, and we have to, yes, for the next future, we have to make it more, yeah, I think continue to do it. Yeah. And bendamustine offers significant benefit. I have a colleague that's already given bendamustine for some cycles, 2 or 3 cycles, but the results was not declared until now. So I think we have to wait for bendamustine results from my colleague.
Yes. Will you comment, Professor? Dr. Hillman is asking because bone marrow transplantation is regarded very still. If we want to ask bone marrow transplantation, we have to fight first, discuss first, etc. And Dr. Hillman is asking, in those cases where we have to wait too long to get approval for bone marrow transplantation, can we change resistant large B-cell lymphoma to bendamustine?
Can we?
Use direct bendamustine rituximab to large B-cell lymphoma who is not who is resistant to R-CHOP.
Yes, yes. This is a current treatment in Germany. In the literature, you find gemcitabine oxaliplatin, and we use in Germany, and this is also done in many countries now, bendamustine rituximab in patients who are resistant to CHOP-R. This is a good palliative treatment, and this is a standard treatment approach in Germany when you do want to do some palliation, some tumor reduction, and some treatment against the disease. In diffuse large B-cell lymphoma after R-CHOP.
So there is a solution for us, yeah? Bone marrow transplant is still regarded it's too expensive because it needs the facilities, the doctors, etc. And if you can use bendamustine in the meantime, it will help very much for us, yes. So especially with frail patients, older patients,
yes,
which cannot continue R-CHOP, because high percentage of our patients don't continue treatment just because they don't like. Just they don't want to continue because of side effects. I think it's a good solution for us. Yes, thank you very much. Other questions, please? How much time do you still have? Have any questions? Yes. Do you still have some other questions in the WhatsApp? No? Yes. Some other questions from your audience? Oh, yes. This is it. Based on your experience using bendamustine in Hodgkin lymphoma, how good is the efficacy? Can you answer?
Bendamustine is known as a highly active agent in Hodgkin disease. However, ABVD will stay the standard, and this is without bendamustine. So ABVD is a standard around the world for Hodgkin. In case patient relapse, bendamustine is an excellent salvage regimen. So bendamustine has high efficacy in relapsed patients. Of course, when you have a patient who does not respond to ABVD, the response rate of bendamustine cannot be so good. So of course, not all patients respond, but the response rate is around 50% when patients relapse after bendamustine. And the literature recommends in relapsed patients bendamustine plus brentuximab, anti-CD30 antibody, together with bendamustine. However, again, this is a very expensive treatment because the CD30 antibody brentuximab is very, very expensive. So bendamustine is a good backbone, and brentuximab also can be used.
Thank you very much. Because now we have the chemotherapy bind to antibodies, which is very strong, but very expensive, of course. Yes, still other questions of this stand? Last. Some questions from the audience? Still have questions there? No? Well, I think we...
The time is up.
Yes, the time is up. We have to stop now. It's supposed to stop at 12 o'clock, isn't it? Yeah? Okay. But we are only 10 minutes passing. But I think I'd like to thank you very much, Professor Rummel, for your existence here, and Dr. Hillman also. We had a very interesting discussion today, and I think it is very fruitful, very important, and I hope that it will change us. The most important thing is that when people go out of the room, they can have a change of behavior. And the most important change of behavior, I expect you, at least you have to put some more time for your patients after to explain what's going to happen. And secondly, please read, because science is very important. We have to continue. Medical oncologists have to continue reading literature. Every day you have new literature, new things. And to make a decision, you must have please take your time. Consider the condition of patient. The systemic condition of patient plays a very important role in choosing, not just choosing from the book and see which protocol you be used. It's not like that at all. Well, thank you very much, because everybody has been, for your patience, you've been listening here until the end of our trial. And thank you, of course, to Professor Rummel for your purpose. Thank you very much.
We thank all the speakers for interesting discussion. Please stay on the stage.
Thank you very much.
Definitely, the discussion is already leading that the RB is now being preferred from RCHOP. Please all speakers stay on the stage. We would like to invite also Dr. Lutra Burning to join the speakers on the stage. Okay? Yeah, okay. We would like also to invite Mr. Christian Topanji as the CEO of Veron to the stage and deliver the commemorative signs to all the speakers.
I'm not the speaker, you should.
Prof. Maris.
Can we move forward a little bit so that the photographer will take a picture? Chris, can we move forward a little bit?
Oh, yeah.
Yes.
Turunnya saya sama kamu ya.
Yeah.
Oh ya, oke, ya atas nama Perompedin, terima kasih pada penyelenggara. Kami amat menghargai pertemuan semacam ini dan kami harap semua farmasi akan mengikutinya, menyelenggarakan membantu kegiatan ilmiah di antara para onkolog di Indonesia. Terima kasih. Terima kasih untuk.
Terima kasih Prof. Ari and all the speakers. You may come down. Yes.
Okay.
Thank you very much. Oh, sorry. We will take a picture together, huh?
Okay.
Yeah, please. Okay, thank you very much. Ladies and gentlemen, this was the end of the Rudy Soetikno Memorial Lecture. We do hope that the audience received the benefits of all discussion on bendamustine, especially the new regimen, bendamustine rituximab. Veron's brand on the bendamustine is called Vancomustine. It's already available on the hospital pharmacies in Indonesia. Vancomustine and bendamustine will be included in the Formularium Nasional starting April 1st, 2018. We hope you enjoy the whole program as much as we have prepared the program for you. apologize for any imperfection that may cause your disappointment in the program. Appreciate your attendance, and lunch has been prepared at the served in the lobby of the Titan Theater. Thank you very much, and good afternoon.
Was when I ruled